Disease and Critical Care from University of Milan. He has been an avid researcher, a member of ESICM working group, the Plug group, the Pleural Pressure working group, as well as the Italian Society of Critical Care Medicine. And his seminal work is in ARDS, hypoxic respiratory failure, the utility of ECMO, the determinants of respiratory drive and villi. A lot of good work. Professor, requesting you to talk about the respiratory support for this, the golden sweet spot, the ARDS with PF ratio 150 to 200. Over to you, Professor.
Thank you for the invitation. I will speak about, let's say, some novelties in the respiratory support in patients with ARDS, but not intubated yet. You can ask me questions during or after, and we can discuss. So what are we talking about? This is a typical patient from our unit. Let me take the pointer. So this is a patient with pneumonia, and this is the ABG. So the PCO2 is low, is not high. And this is a sign of increased respiratory drive. The pH is 7.5, so respiratory alkalosis. The respiratory rate is high, and the PF ratio exactly what is asked in the title, so 160. So this is a patient that you might not intubate right away, but this patient is very severe because the evolution of his or her syndrome is to become ARDS. If pneumonia becomes ARDS, the mortality goes up to 30-40%. And this is another patient, very, very similar. Lobar pneumonia, PF around 160, respiratory rate 40, low pH CO2. So in the, let's say, respiratory classification of these two patients, the diagnosis is the same and the severity based only on oxygenation is the same, 160, 159. The difference is that this patient has pH 7.19. So this patient, in addition to pneumonia and hypoxemic respiratory failure, has metabolic acidosis. So the respiratory drive of this patient is increased by two determinants. The pneumonia, same as the other one, but also the very low pH due to metabolic acidosis. So the patient needs to compensate by lowering PCO2. So the respiratory drive of this patient will be much more activated than the first one, and the risk of progression to ARDS through PSILI, patient self-inflicted lung injury, is much higher in this patient. So it's interesting that when we speak about patients with I will not call them with ARDS, I will call them at risk of ARDS from pneumonia, the PF ratio is not enough to understand the severity. The severity is the number of determinants of respiratory drive that are outside the physiological range. Why this is relevant? This is a study that we published now in respiratory research, and we let 18 pigs breathe spontaneously for 24 hours, starting from the same baseline injury, LPS, so let's say pneumonitis, to the left lower lobe. After 24 hours, the right lung that started healthy deteriorated, had acute lung injury. This is the histological score. But the severity of this score is very wide, from almost normal to very severe injury. So we plotted this injury to the right previously healthy lung with respiratory drive, P0.1, with inspiratory effort measured by occlusion pressure and esophageal pressure swing, And you see the trajectory, the correlation. The more the drive, the more the effort, the more the injury to the previously healthy lung. So this is the risk of progression from pneumonia to ARDS, from lobar consolidation to bilateral lung injury. So what is critical in patient with PF around 100 to 200 and more localized insult, so pneumonia, aspiration pneumonia, but also lung contusion could be from trauma. What is critical is to control the respiratory drive within and the respiratory effort within normal ranges. P0.1 is we cannot measure much, but maybe with the non-invasive ventilation we could. So normal range is between 2 and 4. And esophageal pressure we can measure in patients with high flow, for example, or with an IV, and the normal range is between 5 and 8, as shown here, to keep a risk of PSIDI, patient self-inflicted lung injury, low. Is this true also in patient or only in animals? This is a study showing that if you don't decrease the inspiratory effort and the PEEP needed to maintain it, if you don't decrease over the days, you end up intubated. Instead, if you decrease the effort, you don't get intubated. So non improving and worsening respiratory failure is due to uncontrolled respiratory effort, risk of patient self-inflicted lung injury in COVID-19. So from pneumonia to ARDS, the mediator is effort. This is another study showing something very similar. These are patients that are started on NIV, and those with NIV failure, meaning intubation, these are hypoxemic patients on NIV, don't decrease esophageal pressure swing when they are started on NIV. Instead, those decreasing the effort on NIV are NIV success, don't get intubated. So these are two studies, two inpatient, showing something very similar to the mechanism shown in animal. Uncontrolled drive is the determinant to switch from lobar, more contained lung injury, PF around 150 to 100, to a bilateral lung injury, ARDS, intubation, mortality going up to 30-40%. So what is critical is to assess inspiratory drive and effort. The more the effort, the more the risk of evolution. This should be our main monitoring and not PF ratio. So there are, this is a review we wrote this year, last year with a group of friends, and there are a number of measurements that we can have also during high flow. On NIV, face mask NIV, the number of parameters correlated with effort even increase. So, for example, in our unit, in our clinical practice, for sure, we use the ROX index. We ask the patient the dyspnea score. Sometimes we use esophageal pressure swing. This breath score is something we developed, is a non-invasive based on physiological parameters. And during an IV, for sure, we use the tidal volume, the POC and P0.1. There are, if the mask don't have too much leaks, it could be measured even during an IV. But this is to stress that before arriving to RDS, in milder patient, we should monitor effort. The breath score, for example, is a way to detect higher esophageal pressure and esophageal pressure above 10 based on a simple measure at the bedside. This is interesting to show, for example, that the base excess, as I showed you in the previous cases, if you have respiratory alkalosis but with very low pH due to metabolic acidosis, this is a risk factor, additional risk factor for having high inspiratory effort, in addition to the respiratory rate and the PF ratio. The ROX index is something we use in clinical practice. It's very simple, SpO2, FiO2, respiratory rate. You have straightforward numbers, so less than 3.85 or more than 488. Here are examples. If you are above 488, usually you don't get intubated, usually. Instead, with less than 3.85, it's very likely that the patient in the following hours will be intubated and you need to step up. Either you intubate right away or you change the type of support because the ROX index was validated on high flow. There is also a gray area between 3.85 and 4.88 that we don't know. But these are severe patients and usually are those with the PF ratio between 100 and 200. So if we go back to the two patients, we can, in addition to, let's say, the clinical picture, add this score. And for example, it's interesting that the patient one, the ROX index is 7.7. So it's 6.7, so above the 488, and the breath is kind of low. Instead, in this second patient, the ROX index is 4. So this is very interesting because the 4 is in the gray area. It's not below 3.85, but it's not above 4.88. So it's exactly, we don't know. This patient is very severe. Maybe you don't want to intubate right away, but you should be careful. And the breath is very high. So this patient is at higher risk of having strong inspiratory effort as compared to this patient, despite having the same PF ratio. Okay, so PF ratio is just the starting point, but we need to arrive to the risk of high effort. To make a long story short, this patient was intubated and then also put prone, had severe ARDS, put prone, recovered, ventilation days like 2-3 weeks, and then discharged from the ICU alive. This patient was intubated after 2 days and died after 2 days. So 3-4 days after this ABG, this patient, around 65-year-old, died. Okay, so these are apparently milder patient, pneumonia, non-intubated, but in reality, these are the candidates to become ARDS, and their mortality can escalate to 30-40%. And even if they don't die, when they end up intubated, they remain in the unit for 2-3 weeks. Okay, so the cost is very high. So what is crucial is to avoid the evolution. So respiratory drive is not only gas exchange. This is a review we wrote, and PaO2, PCO2 for sure are determinants, but also pH. So metabolic acidosis, for example, are biochemical input to the respiratory drive. But then there is also inflammation. So a patient that is more inflamed, so we can take a look at body temperature. Body temperature of 40 is different than 38.7, even though they are both elevated. Or we can take a look at C-reactive protein or procalcitonin. These simple inflammatory biomarkers. Then there is agitation, pain, discomfort, anxiety. This increases the respiratory drive. So a patient that is very agitated or not or in pain with a high dyspnea score, discomfort, will have respiratory drive elevated. And final, the mechanical input is a negative feedback. The more the infiltrates, the more the collapse of the lung, the less this negative input. So the respiratory drive activation is also a vicious circle. The more you increase the edema to the lungs that are previously healthy, patient self-inflicted lung injury, the more the activation of the drive, because PF ratio will become lower and lower, because the patient will get more agitated, because shortness of breath will develop, because you have a larger collapse in the lungs. So the idea is that we should modulate all these determinants, ideally, not look only at oxygenation, and avoid excessive respiratory drive leading to patient self-inflicted lung injury. Okay? What is the best, let's say, non-invasive respiratory support to obtain this goal of modulation of respiratory drive? So high flow is 30 to 60, maybe there are also now experience with flow higher than 60, heated humidified air and oxygen at a set FiO2. Is a non-invasive respiratory support and not simply a lot of oxygen. Why? Because the mechanism to modulate respiratory drive by high flow are multiple. This is one, which is a better correspondence between FiO2 set and the one reaching the alveoli because of less room entrainment, and the PEEP effect. These two collaborates to better oxygenation, but also to better lung mechanics. How much is the PEEP? PEEP increases linearly with flow, but it's very different between mouth closed and mouth open. So mouth open, the PEEP is between 30 and 60 liter, is around 2 centimeters of water. The PEEP between 30 and 60 liters with the mouth closed can arrive to 5 to 8 centimeters of water. So what is interesting from this data, this is a physiologic systematic review we wrote, is that there is always some PEEP with high flow, but it's predictably variable and fluctuating. This is a advantage for high flow because the patient can speak, can eat, can interact as compared with the closed system with a face mask. But on the other hand, if you think that your patient improves, benefits from PEEP, high flow is not the right non-invasive support to deliver constant, fixed, higher PEEP. But on the high flow has also other effects. So one is better oxygenation. Second is PEEP effect. Third is reduced dead space. By the CO2 washout, the patient can breathe less, minute ventilation decreases with the stable PCO2. So the need to clear PCO2 is reduced by the washout of the upper airways. How much washout? So around 20% decrease of the minute ventilation. You see here, this is around 20% reduction of minute ventilation, of alveolar ventilation, and similar data here, around 20% of improvement in CO2 clearance. This is a specific mechanism for high flow. The other respiratory non-invasive support don't have this improvement in CO2 washout. This will decrease effort because the patient needs to breathe less to maintain the same CO2. PEEP will decrease effort because of better mechanics. Better oxygenation will decrease effort because of better PO2 to the brain. Indeed, all these mechanisms together lead to reduced effort. Esophageal pressure swing passing from 10 to around 8, and esophageal pressure time product going to more normal values, around 150. This is pressure time product, the work of breathing. This is the esophageal pressure swing in a spontaneously breathing patient. However, after 24 hours on high flow, Our patient, the first one to the left, worsened. 24 hours, PF ratio goes to 100, respiratory rate 32, and the ROX index went from 6.7 to 4.7. So this is another interesting message. The ROX index can evolve. Don't look only at the starting one, because this was safe, above 488. But the new ROX index is below that level. So we have three indication of worsening respiratory failure. So this patient has more bilateral infiltrates, lower PF ratio, and lower LOX index. So this has become at high risk patient for intubation and higher mortality. So we should step up. So one idea could be to increase high flow to flows higher than 60 liters per minute. We tried this, we arrived to 100 liters per minute in this study, and there was a sign of better PEEP effect and lower inhomogeneity of ventilation, so some physiological benefits, but the comfort at very high flow rates was very poor. So it dropped from 8 to 5. So high flow at flows delivered above 60, there are systems allowing you to do this, but the comfort might be poor. Another option when the patient is worsening or non improving with a standard high flow is awake prone position. This study showed that when the patient is prone for a few days, when the patient turns back supine, if there is a recruitment measured, for example, with ultrasound of the dependent lung, then the patient is going to be a success. Okay? The patient, when he's turned supine, there is a residual recruitment by the awake prone position. And this is when it succeeds. Sometimes, however, it fails. How much shall we prone the patient on high flow that are more severe or non improving? This study showed that 12 hours is associated with better clinical outcomes, intubation, as compared to 5 hours. So if we decide, and mortality is reduced too. So if we decide to turn a patient prone in the awake prone position with the high flow, we should keep them long, okay? 10, 12 hours during one day. So one session in the morning, one in the afternoon, and maybe sleep overnight on the prone position. And this will lead to success. Then there is the asymmetrical cannula with the asymmetrical flow that we showed that at 40 and 60 liter per minute reduced the minute ventilation, the esophageal pressure swing with stable PCO2. So there is a better CO2 washout by the high flow asymmetrical cannula, and this can be seen as a step up option to decrease esophageal pressure swing, so the work of breathing of the patient, the effort, which is the critical goal when supporting a patient by non-invasive respiratory support. So I showed you three methods to improve the effects of high flow that are already feasible, going to flow higher than 60, away from position, and asymmetrical cannula. Instead, this is a new frontier, which is bi-level high flow. So during inspiration, the flow is higher, and during expiration, the flow is lower. This works as similarly to a pressure support and decreases the pleural pressure swing, which is the inspiratory effort. We tested this with AI on digital twins. It's not already commercially available, but it's a very interesting development. So high flow is a powerful respiratory support, should be titrated individually, and should be monitored over time for the goal of decreasing effort. A couple of words to other system. We do use the helmet, which is a stable eye PEEP, and the helmet has some advantages to high flow, especially in terms of oxygenation. Instead, CO2 rebreathing is a problem. High flow has the washout. This increases the CO2 breathability, so the helmet can increase the dead space. And so the work of breathing not always reduced, only when the PEEP effect obtains some recruitment. An alternative is to use the helmet NIV. This is currently tested in ongoing randomized clinical trial, and there are previous studies, one small study and a meta-analysis showing some advantages. So if I would say, when you have a patient that you start with high flow, not improving, then you make addition to high flow, asymmetrical cannula, wave proposition, not improving, then you can switch to helmet NIV, but it's still experimental and can be a little difficult to apply. What about standard face mask NIV? We know the physiological effects, improved oxygenation, not much CO2 rebreathing. For sure, is the most powerful to decrease work of breathing. Okay, so apparently the effort of the patient will go down, but clinically, the non-invasive ventilation in patient with PF 100 to 200 is dangerous. In the Florally study, comparing high flow with standard oxygen and non-invasive ventilation, in terms of mortality, the worst was non-invasive ventilation. And in the lung safe study, patients with PF ratio below 150 did much better when intubated right away than when kept on standard face mask NIV for a few days. So when you start a patient on standard face mask and IV, it's like a last resort. Be careful, monitor the tidal volume. If the tidal volume is too high after 2-3 hours, even though you have better oxygenation, if effort is not controlled, you'd better intubate. And I would say I will stop here. Thank you. This is like a summary.
Thank you, Dr. Mauri, sir, for a wonderful, wonderful talk, very insightful, and updated till today. I think it's very insightful. So I request the audience, Dr. Mauri is here. If you have any questions on this or pulmonary ventilation, please go ahead. You will not get better person to ask from.
Thank you, Dr. Mauri. It was a wonderful, presentation. Can you quickly tell about the BREF score for the audience? Just a little bit how to use it, the BREF score for the.
Yes, I think that the BREF score is still being validated. I go back to the slide and you can check. I think it's very interesting for the concept. We are still validating it in a prospective study. So this was the study. This was more than 200 patients on a flow and with esophageal pressure swing. The linear regression was first univariate, then multivariate. The multivariate retained the determinant of increased esophageal pressure swing. So if you have a COVID-19 diagnosis, because this was done in 2024, so many patients had COVID here. If you have a high respiratory rate, if you have a lower base excess, and if you have low PF ratio. Okay, so the lower the base excess and the lower the PF ratio, the higher the risk of esophageal pressure swing. This is another model to predict like only strong. This is the linear approach. This is only for strong inspiratory effort. So above 10, and the three determinants were respiratory rate, low base excess, and low PF ratio. So I think this is doesn't have fixed yet values. This is the calculation to do it. Can be done at the bedside. But by now, I think what is important is to understand the concept that high respiratory drive and effort don't come only from PF ratio. The acid-base status and the, for example, respiratory rate, or also we look at respiratory mechanics. If the patient is asynchronous, the thoraco-abdominal synchrony, so the appearance of the patient is very important.
Thank you, Dr. Mauri.
Dear viewers, any question? So I think, sir, there are no questions. It was really wonderful. Dr. Mauri, sir, look forward to having you again on our educational programs. Thank you very, very much. It was an honor.
Thank you. Bye-bye.
Bye-bye, sir. Bye-bye.
Thank you. Thank you.
So, guys, we close this session now, and we wait for the next talk. We are waiting for the speaker, Dr. Samir Jaber, who is the editor-in-chief of Intensive Care Medicine Journal, and his talk would be to optimize intubation in the ICU. What is the best way? So, kindly wait for him to join. And Dr. Ansari, sir, thank you very much for moderating the sessions. Grateful.